And I will share my screen. And let me reduce this down. Okay, so this week we are going to look at exercise program design with regard to someone who is in active treatment with cancer. And so we're going to look at basically what are the general guidelines of exercise prescription, and then how should we modify them kind of on a more general basis, depending on if someone is in chemotherapy, if someone's in radiation, if someone is in surgical recovery, and kind of talk about some basic principles of things that you should follow when you're prescribing exercise with someone who's in active treatment. Now, keep in mind, this is a very general presentation. And so if you were to go through the Exercise Oncology Instructor certification, if you were to take a course on this, we would go much deeper into some of these ideas and talk about a little bit more specific things. But today, I just kind of want to give a more general overview of this topic so that you can kind of start thinking about ways that you might approach someone who is working in cancer, or at the very least, kind of break down any barriers or any fear that you may have in working with someone who is battling cancer, and just that fear of the unknown, or maybe not necessarily understanding what some of these treatments do. So that is what we're going to talk about today. I'm going to put this in a slideshow to make it a little bit easier for you to see. So essentially, what we want to focus on here is this idea that when someone is battling cancer, cancer itself and the side effects from treatment can result in numerous physiological and psychological changes for that patient. And so the goal of this particular lecture is to focus on what exactly do these changes mean with regard to the exercise prescription and exercise programming. And so we're going to kind of take a very broad topic, and we're going to narrow it down to just those two things: exercise prescription and exercise programming. So I think it's important to start with, well, what are the goals of any exercise prescription, whether somebody has cancer or somebody is completely healthy and doesn't have any chronic diseases. So anytime someone begins an exercise program and you're going to design an exercise prescription for them, the goals of that exercise prescription are probably going to be something like: you want to promote good health, you want to reduce their risk of chronic disease, you want to promote functional independence for as long as possible, and then you want to improve cardiorespiratory, metabolic, and musculoskeletal fitness. So those are goals that can apply to any person, whether they have a chronic disease or whether they're completely healthy. Now, the next step then is looking at what are the general recommendations for a healthy population. And these are based off of the American College of Sports Medicine guidelines that are published for people that are very healthy, have no chronic disease, and you want to help reduce their risk of chronic disease. So starting with an apparently healthy population, what you want to do is you want to try to get that person to 150 minutes of moderate intensity exercise each week. This is aerobic exercise, or 75 minutes of vigorous exercise each week. Now, keep in mind, 150 and 75 minutes, these are that is something that you want to strive for. And so if you're working with someone and they're getting zero exercise, you want to get them up to being able to do 150 minutes of exercise per week, moderate intensity. So that means they can talk. If they can talk, if they can answer your questions while they're exercising, that's a good intensity level for them. And that's a very good initial goal. Now, if you're working with someone who's obese or someone who wants to see further benefit to the exercise program, it's okay to exceed that 150 minutes. So generally, you see guidelines written as 150 minutes to 300 minutes of moderate intensity exercise per week. And if you're able to get them up to the 300 minutes, which might sound like a huge, huge jump for someone who's never exercised before, but if you get someone who's already pretty active and you want to kind of challenge them a little bit more, 300 minutes is essentially 45 minutes per day instead of 30 minutes per day. So it's not that big of a jump, and they will see more benefits to that. So more is better up to about 300 minutes. You also want to encourage them to do strength training. So 2 or 3 days per week, you want them to do strength training. You want to focus on the whole body, all the major muscle groups, 2 to 3 sets of each exercise, and at least 10, 8 to 10 exercises so that you get the whole body when you're performing resistance training. And then also you want to include flexibility. Flexibility is the most neglected component of fitness, but you do want to make sure that you're helping the individual to stretch and to increase their range of motion. That will help them to maintain their functional independence, and it will also just help them to get around better. It helps with their neuromuscular facilitation. So you definitely want to include that as well. And I would recommend including flexibility on the days when exercise is performed. So if you do a bout of aerobic exercise, then end that exercise with about 10 minutes of stretching. That's probably the easiest way to work that in. So these are the guidelines for the apparently healthy population. This is going to be our starting point. And then we're going to look at how do we adapt these, if at all, for someone who is battling cancer. Now, one thing to keep in mind is when you look at individuals who have a chronic disease, most likely, and I say this because about 90% of the patients we work with at Maple Tree have never exercised before. And so it's very common when you're working with someone with a chronic disease that they may not have exercised before. And when they're battling a chronic disease, whether it's cancer or whether it's something else, you're going to see fluctuations in their health status. So there's going to be days when they feel really good and they're going to be able to tolerate higher levels of exercise. And then there's going to be days when they don't feel very good. And on those days, you want to be ready to modify the exercise program. This is not a situation of no pain, no gain. And if you don't do this, then you're not, you fail. You want to try to meet that individual where they are and help them to exercise, keeping in mind that something is always better than nothing. I share this story all the time. I believe I've even shared it here in this webinar series. When my grandfather was battling colon cancer, at the end of his life, all he was able to do was get up out of bed and walk one lap around the downstairs of his house. And, you would, an exercise physiologist could look at that from the outside looking in, and they may think, well, why would you even bother doing something like that? You're not going to increase your VO2, you're not going to increase your muscular strength. Well, for him, that was all he was able to do, but it still made a difference. It still increased his energy levels, it still improved his mood. So something is better than nothing. And it's very, very important when you're working with someone who's battling cancer or any other chronic disease that you meet them where they are and adapt the exercise program to match their current state. So, when we're talking about exercise for the cancer patient, keep in mind that historically patients were told to rest. And sometimes that is what people still believe. And so you may come across a patient who's been newly diagnosed, and maybe that patient wants to start an exercise program. Maybe they had a doctor who talked to them about exercise and the importance of it, and maybe they're looking to start an exercise program. But perhaps, and you need to kind of be aware that this is something that could happen. They may have a caregiver who thinks, oh no, why would you exercise when you're battling cancer? Shouldn't cancer patients rest? Because historically, that is what patients were told. And we have doctors that now understand the value of exercise, and many of them are recommending their patients exercise. But we still have caregivers, we still have well-meaning loved ones who have not gotten that message yet. And they might be nervous about their loved ones starting an exercise program. So keep that in mind and just kind of understand that when someone starts an exercise program, they might be nervous and they might be wondering, is this even safe for me to do? I know my doctor told me to do it, but it just doesn't feel like it's safe, or it doesn't feel like I should be overexerting myself. So be ready to explain that this is safe. There's a lot of evidence. We're going to go through some of the evidence here today on how exercise can help them, but then reassure them that you're going to meet them where they are. And if they're having a bad day, you're going to adjust that exercise program accordingly. Be ready to share that with the patient and the caregiver to put them at ease. Also, keep in mind, what are the risks of physical inactivity? Meaning, If the patient decides to rest instead of doing exercise, what that patient can expect to see is a loss of function, a loss of strength, reductions in range of motion, and negative psychosocial outcomes as they go through their cancer treatment journey. So the risks of physical inactivity are considerable. And, it is important to understand that when someone chooses to rest, that is what they're going to be at risk for as they're going through cancer treatments, because we know cancer treatments are going to cause all kinds of negative side effects in that individual. These are the documented benefits of exercise during cancer treatment. Now, this comes from a 2019 roundtable paper that was published by the American College of Sports Medicine. And what they did was they combed through all of the literature that existed at this time, and they looked to see, of all the existing literature, what is there strong enough evidence that we can say these are documented benefits of exercise during cancer treatment? Now, it's been 6 years since this paper has been published, and there were other things that are not listed here that perhaps now we might have stronger evidence that we could add to this category. But at the time that this paper was written, these were the 8 qualities that were the documented benefits of exercise during cancer treatment. I really hope ACSM chooses to have this roundtable paper again and publish it maybe in 2029 as a 10-year anniversary of the publication of this paper, just to see, in the 10 years since this has been published, what are the additional benefits we can add to this list. But for right now, we know that there is documented strong evidence to show that exercise during cancer treatment can help reduce fatigue. It can improve sleep, quality of life. It can reduce anxiety and depression. It can help with changes in body composition. You see body composition both ways in cancer. Some types of cancer can lead to cachexia, where you see a wasting away of the individual with a lot of weight loss, a lot of muscle mass being lost. And that's, of course, negative. And then other times you have people who are on hormone driven cancers where you see the opposite, and they may gain 30 or 40 pounds during a 12-week span of cancer treatment. And so you see body composition fluctuations in both directions, and exercise can help mitigate some of those fluctuations. The function of the individual, helping to keep them independent. And then finally, breast cancer related lymphedema. All of these are characteristics or benefits of exercise during cancer treatment. We also have very strong endorsements for exercise oncology. These are national and international organizations that have, since the publication of the roundtable papers by ACSM in 2019, have come out and said, yes, we endorse exercise oncology for cancer patients. And so the 2 most notable ones that I want to point out here is the very first one on the list, ASCO. That's the American Society of Clinical Oncologists. They released guidelines in May of 2022, which essentially said any cancer patient who is being treated with curative intent should be referred to an exercise program. It was the strongest statement by a clinical oncology group here in America to date that has been written. So that was a huge step forward in our quest to get exercise recognized as part of standard of care. And we really were glad that they kind of took that step to say this is what should be. Patients should be referred to an exercise program. And then right next to that, the National Accreditation Program for Breast Centers, NAPBC. This is a group that works with breast centers. So if I'm diagnosed with breast cancer and I'm going to go to an NAPBC accredited place to get my breast cancer treated, these are guidelines that breast center is held to, and they publish them, I think, every other year. I think they release updated guidelines and updated standards. And as of the publication of January 1st, 2024, they had written exercise into those standards in 4 different places. So beyond just a checkbox, like telling someone to take a walk, now suddenly patients should be assessed. Their functional abilities should be measured, and they should be referred to an exercise program, an evidence-based exercise program, and that needs to be documented in that patient's EMR. So it was a very great step forward. This is actually something that we're using now to try to get CMS approval for insurance reimbursement for exercise oncology, because you have this standard that breast centers are held to. And so that kind of opens the door then for a payment model to take place. So we're working on that. Stay tuned. In Mapletree, one of the things that we very strongly promote is individualized exercise programs. And so that means assessing the patient, finding out where they are, what is their starting point, what are their strengths, what are their weaknesses, what are their goals, and then adapting the exercise program specifically to that patient. And so it's not a one size fits all approach. But if you think about it, that's how cancer is treated. It's never going to be the same for every patient. Every patient is unique. They all have a unique health history. They all have unique, status of, whether they're working, whether they have transportation, whether they have a loved one to help take care of them. All of that is taken into consideration. And so exercise programs are the same thing. We are going to take that person into consideration. We're going to find out where their starting point is and how we can help them to thrive while they're being treated for cancer. And so the first thing that we do on any patient that comes in is a pre-screening. We're going to find out their medical history, their cancer history, their quality of life, their symptom severity, any psychosocial aspects that we should know about, and basically get that well-rounded view of the patient that we're going to work with. And then from there, we have the patient complete a fitness assessment. And I'll go into what the components of the fitness assessment is in just a little bit. But essentially, this fitness assessment is going to look at every major component of fitness. So we're going to look at cardiovascular endurance, muscular strength, muscular endurance, range of motion, balance, posture, body composition. And we then will be able to look at those values from the fitness assessment and determine what are their strengths, what are their weaknesses, and where do we need to focus this exercise prescription on? And then that exercise prescription should mirror exactly that data. So if we find that someone has a very, very low cardiovascular endurance, well, then we want to make the exercise prescription to help that person improve their cardiovascular endurance. If someone comes to us and they've just had breast cancer surgery and they can't raise their arms up overhead, well, then we want to make sure that that exercise prescription is addressing their range of motion limitations and helping them to improve their range of motion of their upper body. So everything that is identified in the fitness assessment should be addressed in the exercise prescription. From there, you have the exercise programming, and that's the execution of the exercise prescription. And so at Mapletree, what we do is we have 12 weeks of exercise programming, and we have enough funding at most of our sites to meet with patients one time per week. Now, if you remember back to the guidelines from ACSM for healthy individuals, we want healthy individuals to get about 150 minutes of exercise per week. That's a tall order to do that one time per week. And so while we're meeting with our patients one time per week, we also give them homework and we also give them the tools that they need so that they can exercise other days per week without their trainer, but teaching them how to do the exercise program, which also helps to build their self-efficacy, and it gets them closer to that goal of 150 minutes. And then finally, the last thing, but I believe it is the most important thing on here, is reevaluations. What that means is every 12 weeks, as the patient moves through the exercise program, we repeat the fitness assessment. We also repeat the surveys that we give them. And that gives us tangible data then that we can report back to our health system partner. So we can say, okay, Johnny just completed phase 1, 12 weeks of this program, and he saw a 10% improvement in muscular endurance and a 15% improvement in cardiovascular endurance. You report that back to the health system. That helps the physicians and the nurses and the social workers to believe in your program and to see, wow, there's like really tangible benefits here. Patients get stronger when they're going through chemotherapy. Like, that blows my mind that that's possible. And yet we see that all the time. So it's beneficial for that to build the credibility of your program and the support of your program with the medical community. But you also share that data with the patient, and that is huge for the patient, because putting yourself in the patient's shoes, what if they've never exercised before? and now they have cancer and they don't feel good and they're so scared for what the future may hold. And it's probably such a hard thing for them to show up week after week after week and push their body and do these exercise programs. I once had a patient tell me she was more afraid to come to Mapletree for her exercise program than she was to do her chemotherapy. And so if that is their mindset and you reassess them and you find that they have a 10% improvement in their muscular endurance, a 15% improvement in their cardiovascular endurance. I mean, these are numbers that we see all the time. We kind of take them for granted, but you show that to a patient, they're going to be so proud of themselves and they're going to think, oh my goodness, here's something that I thought would kill me. And yet it's making me stronger. And that's going to motivate that patient to keep exercising, ideally for the rest of their life. And it's going to build their self efficacy, it's going to build their confidence, and it's going to make them just feel so much better about this journey that they're on. And so I think reevaluations are so important, sharing it with the medical team and sharing it with the patient so that they can celebrate how far they've come. Now, with Mapletree, what we do with our patients, and this just kind of helps us stay organized, and we use this information as we're putting together an exercise prescription, is we classify patients into phases depending on where they are in their cancer treatment journey. So we have a phase 0, which is the prehab phase. I'll get into what that means in a minute. We have phase 1. This is someone who's currently in chemotherapy or in radiation. With the phase 1 patient, we really want to protect their immune system here. If you remember in past webinars, I've talked about the inverted J hypothesis, which basically says if you don't exercise at all, and if you exercise at too high of an intensity, you start to see decreases in the immune system. But if you can keep the patient in a low to moderate intensity, that's where they have the boost to their immune system. That's the phase we try to keep people in when they're in chemotherapy and radiation so that we can protect their immune function so that they don't have chemotherapy dose delays and dose reductions and they can stay on their treatment plan and ideally beat that cancer right into remission and enter long-term follow-up care. A phase 2 patient is someone who has completed chemotherapy or radiation, or maybe they didn't need it. Maybe they just had surgery and hormonal therapy. Our goal with phase 2 is to improve their self-efficacy, to increase the intensity of exercise that they're able to tolerate, get them to that 150 minutes of exercise per week. And then they enter phase 3, which phase 3, ideally, as far as I'm concerned, phase 3 should take place in a community-based setting. And so at Mapletree, one of the things that we do is we partner with fitness centers and we go into fitness centers and we train them and certify them with our certification that we partner with Livestrong on, and we give them the tools that they need so that when a patient completes active treatment, we could refer them into this community-based program so that they can continue exercising for the rest of their life. So this is the basic phase system that we follow. So we just instinctively know if we have a phase 1 patient, that means they're currently in chemotherapy or in radiation, and we need to protect their immune system. That's just kind of how our brains work when we're working with patients. Another thing to keep in mind when you're working with someone who has cancer or really any chronic disease is you do want to obtain physician clearance. This will help you just in case there's any limitations or contraindications. Ideally, what you want to do when you're obtaining that physician clearance is to give them details on the mode of exercise, the frequency, the intensity, and the duration of exercise that the patient is going to undergo so that the physician can come back and say, okay, this sounds good, but don't allow the patient to lift more than 10 pounds or, do smaller bouts of activity or watch for dizziness upon standing or whatever it may be. You want to get those guidelines from the physician so you know to incorporate that into the exercise prescription. Another thing that I think is really important, and we've already kind of touched on this a little bit, is to keep in mind that continuum of the cancer experience. And so you're going to have a patient have a good day and then a bad day. That ability of the patient to exercise is going to change frequently during the cancer experience. So you want to take that in consideration and you want to be ready to adapt the exercise program accordingly. If the patient trusts that you are going to do that, you're going to meet them where they are that particular day, they're more likely to adhere to the exercise program. If they come in and they're having a bad day and you're like, doesn't matter, this is what the prescription says, get on the treadmill, we're going to put you at 65% of your VO2 max, and they can't do it for that day, guess who's not coming back the following week? That patient, because they're going to feel like you didn't listen. They're going to feel unseen, unheard, and that's not the experience you want them to have. So you want to meet them where they are for the entire continuum of the cancer experience, understanding that it could change from day to day. Another thing I want to keep in mind is I'm gearing this lecture towards this middle tier right here, the certified exercise oncology instructor, the trainer who's going to work with the patient while they're in active cancer care. But it's important to note that there is a continuum of interdisciplinary care. And when you're thinking of the field of exercise oncology, the certified exercise oncology instructor is one person of a couple of different people who play a role in this continuum. So at the very top, you have the specialist. That's your PM&R doctors, that's your physical therapists. They're going to work with patients who have functional limitations and help that patient to overcome those functional limitations. That middle tier here is the certified exercise oncology instructor. These are the individuals who work with the patients in active cancer treatment. So what we're talking about today. And then that bottom tier is the community exercise oncology trainer. These are people who work in fitness centers who are certified to work with a cancer survivor, but they may or may not have a college degree. So really, I think what separates one tier of this pyramid from the next is what is their degree and what is specialty certification. So of course, a physical medicine doctor is an MD, a physical therapist generally will have a doctorate in physical therapy, and they're probably going to have some kind of specialty training in oncology on top of that. The certified exercise oncology instructor will have at least a bachelor's degree in exercise science, or they're in their last semester of coursework and they sit for the certification. That's okay. But they're going to have a bachelor's degree at least, plus the exercise oncology instructor certification. And that qualifies them to work in a clinical setting with someone who's in active treatment. And then that bottom tier, the community exercise oncology trainer, our certification for this tier of patient is the Cancer Fit certification. This is what we partner with Livestrong on. And these individuals may or may not have a bachelor's degree in exercise science. As you know, many people who work in fitness centers just have a love of fitness, but they may or may not have a degree. And so we still want them to be trained and to be qualified to work with a cancer survivor. Otherwise, the cancer survivors aren't going to have anywhere to go. And so there are specialty certifications that they qualify for. They just would work with someone who has completed active treatment, but they're still going to have an understanding of cancer and of the unique and long-term limitations and effects that someone who has battled cancer is likely to experience. The way that we can determine where the patient needs to go whenever they're referred to us is this tool right here. This is the Exceeds questionnaire. It's all capital letters, EXCEEDS. This was developed by Kelly Covington Wood, who is an oncology trained physical therapist, and she's a researcher in this space. And she developed this triage tool. Essentially, the patient fills this out, and depending on their answers to this question, we can determine, do they need physical therapy? Are they okay to do supervised exercise training, or can they exercise in the community? So essentially, if they answer yes to one of the questions in this top box here, the red, then they need to be referred to physical therapy. If they answer yes in this orange box here, then they're okay to do supervised exercise training in the clinical setting with the exercise oncology instructor. And then this bottom tier here, this yellow box that you see, that would qualify someone to exercise in the community. If you are looking at kind of the distribution pie chart here, this is based on our patients. Kelly and I published, or we haven't published yet. We're writing a paper, but we presented the paper at a conference just last October, kind of showing what does it look like to use this triage tool in practice, and essentially what do the patients look like that are referred to physical therapy? What do they look like when they do the supervised exercise training? Kind of what does that look like? We didn't have any patients here that were referred to community training just because this was one of our clinical locations. So we had 980 patients take this patient triage tool. Of those, we had 62% that qualified for the supervised clinical exercise training program. And then we had about 43% of patients qualify for physical therapy. Now, of that, I'm not 43, I guess it'd be 48. I can't do math in my head. 38, 38. I need to do math in my head. Sorry. But essentially, about 38% were referred directly to physical therapy. And of those, 14% of those patients were able to do physical therapy in combination with exercise physiology. And so you can kind of see the distribution here of where patients go. And one thing that I want to point out here is sometimes when you're building an exercise oncology program, you have to kind of explain how you're going to work with the rehab team and what does that look like. And just to kind of assure them that you're not going to try to take patients from them, I would recommend showing them this tool because this right here shows that we are going to stay in our lane. We're going to see the limitations of the patient. If it's beyond our scope of practice, we refer out. And actually, we drive referrals to physical therapy. You can see an increase in the number of patients that you're serving and an increase in your referrals. And that kind of shows them that you're going to stay in your lane, you're going to drive referrals their way, and you're going to keep an open channel of communication so that you can both work together to help that patient. We're both on the same team. We just have different lanes that we're treating patients in. And so we need to make sure we stay in those lanes. So what that looks like whenever you're going to incorporate exercise into a physical therapy program is this. A patient is diagnosed. If you get to them in prehab, which is the time of diagnosis until treatment begins, oftentimes a physical therapist can do this. It's a one-time PT evaluation and screening. They get baseline measurements. They can start that patient kind of on this journey on how they're going to stay active and healthy during their cancer treatment. Then the patient can move on to phase one, which again is during chemotherapy and during radiation. If the patient has an functional impairment, they can stay with physical therapy here. They can, if they want to, if they're not too burdened with their number of doctor's appointments that they have per week, they can do physical therapy in parallel with exercise, or they can do them, you finish the physical therapy, then you're referred on to the exercise therapy. It just really depends on what the patient really wants to do. And then phase two is generally done by an exercise oncology instructor. And then phase three then would take place in the community. So you can see how you can incorporate an exercise program in an existing rehab program. We have models like this all over the country where it's either a clinically based physical therapy group that's already integrated into the health system, and we triage patients accordingly and refer them to that program. And then we have a couple of instances where it's a standalone physical therapy group, and we have an exercise trainer that works in that physical therapy group to assess and triage patients and work directly with physical therapists. So it can be done. It is just very important to understand that you need to have those open channels of communication and you need to stay in your lane and refer out when necessary. When you're performing the fitness assessment, these are the fitness tests that we do at Mapletree. So the VO2 max test that we do is the RMCRI treadmill test. RMCRI is the Rocky Mountain Cancer Rehabilitation Institute. That is actually where I got all my PhD work from. It's out of the University of Northern Colorado. And a couple years after I graduated, they created this treadmill test that's specific for cancer patients. And Mapletree actually was the organization that validated this treadmill test in cancer patients on sea level, because Northern Colorado, of course, is high altitude. So we were the group that validated this test, which is pretty cool. And it was right as I was starting Mapletree, and I've just used it ever since. Before this treadmill test, we had used the Bruce treadmill protocol, which is not my favorite. I don't like that big jump from a 0% grade to a 10% grade. I had a patient actually once have a stroke whenever I increased it up to 10%. So I never liked the Bruce treadmill protocol. This is a very nice treadmill test. They're 1 minute stages. And so every minute you're gradually increasing the intensity, the grade, the speed of the treadmill, and then it's until volitional fatigue. So it is a great treadmill test, and it's been validated in a cancer population. Generally, we'll do the skin fold assessment for body composition. The times that we wouldn't do skin fold is if the patient had like recent surgery, we're not able to get to that particular fold of skin, or we have had a couple of instances where the patient just wasn't comfortable with us doing skin folds. And in those instances, then we do bioelectrical impedance. For the muscular strength test, we do a hand grip dynamometer for muscular endurance. If they're able to get down to the ground, we'll do a partial curl up test. If not, we'll do the sit to stand test. I think it's like a 30-second sit to stand, or the 60-second arm curl test. And then range of motion, we do modified sit and reach, and we also do goniometers to measure upper and lower body range of motion. And then for neuromuscular assessments, we do a balance and a postural assessment. So you can see here that this is a well-rounded approach to fitness assessment. We're not leaving out one of these areas. We're going to measure all of them. We're going to get that patient's strengths and weaknesses on every component of fitness so that we can take that into consideration when we're doing the exercise prescription. Always keep in mind that safety is going to be foremost when you're coming up with an exercise prescription, and you need to adapt that exercise prescription to the condition, abilities, and interests of that person. So if the person comes to you and while they're doing their treadmill test, they're like, man, I hate to run. Well, don't make their exercise prescription so that they're running. You want to find something that they enjoy doing, because then they're more likely to keep doing it than if it's an activity that they hate, they're not going to come back. So you want to adapt it to that patient. So we talked about getting physician clearance. We talked about the fitness assessment that we do. Now let's talk about the exercise prescription according to those phases that we just talked about. So what do you do when you have someone who's just been diagnosed who hasn't started treatment yet? This is the prehab phase. We call this prehabilitation. So this means this person has been diagnosed with cancer, but they haven't started treatment yet. So usually you get a little window of time here where you can get baseline measurements from that patient, and you can just start talking to them, educating them about the benefits of exercise and about how you're going to help them to be healthy and to be active while they're going through cancer treatment. Ideally, this is the first time you would see the patient. They would be diagnosed with cancer, and then they would be referred to your exercise program, and then they would come. That doesn't always happen, but in a perfect world, this would be the first time that you would see the patient. So you can get those baseline measurements, because when someone comes to you and they're in the middle of chemotherapy and you do the fitness assessment, it's not going to give you a true baseline of that person because they're in chemotherapy. So they're going to have a lower functional status than what they would have before they started chemo. Now, one of the things to keep in mind, and then this is not across the board, but a lot of times surgery is going to be the first line of treatment for someone who's newly diagnosed. And so you want to keep in mind that after surgery, that patient is going to experience an impairment in the form and function of the organs and of the tissues that were involved in that surgery. You also want to keep in mind that individuals who have a low muscle mass at the time of diagnosis, that is correlated with greater treatment-related toxicities. Meaning, if you have someone who is sedentary and has a low muscle mass at the time of diagnosis, research shows that they're probably going to have more treatment-related problems while they're going through treatment, and they're probably going to have a higher mortality rate than someone who is exercised. And so if you get someone during this prehabilitation phase who has a low muscle mass, and you have a little window of time to prepare them for surgery, you can boost their muscle mass in that little window of time, and that will help them have fewer treatment-related toxicities and potentially even lower mortality rates than if they had not started that exercise program. So it's really important to take advantage of that window of time when you're given that with the patient. When we're looking at the basic principles of exercise prescription for someone who's in prehab, you want to follow the basic principles of exercise. And so you want to do the pre-screening evaluation of that person. So have them do the medical history, cancer history, find out the medications they're on, find out their quality of life, all of those things you want to find out. You want to do the fitness assessment, and you want to also consider what treatments are they going to get, and kind of have an idea of what are going to be some of the side effects that we can expect to see as you go through this treatment journey, because ideally you're going to be with them every step of the way. So you want to anticipate what is to come so that you can account for that in their exercise prescription. With prehabilitation, you really want to focus on optimizing their pre-treatment health status while you're also improving patient outcomes post-operatively. And this is going to be based on the screening. You want to address any functional impairments that they have and then what they can prepare for as well. So be sure that you're addressing all of that. And then while they're undergoing treatment, you want to keep in mind that there are going to be treatment-related toxicities and side effects. And ultimately, the goal of exercise during treatment is to manage those treatment-related side effects. So you want to help them manage their fatigue. You want to help them to manage the anxiety and the depression that they're going to have, or their sleep disturbances. All of those things we can manage with exercise. You also want to help attenuate the physical decline that happens during cancer treatment. I recently read in a research article that patients who go through cancer treatment generally accelerate in age 10 years compared to a 1 year period for a normal healthy individual. So that means if I'm 45 when I'm diagnosed with cancer and I spend a year in cancer treatment, at the end of that year, I'm 46, but my physiological age that I aged while I'm undergoing cancer treatment for that 1 year period of time put me at a 56-year-old instead of a 46-year-old. So you see a rapid acceleration of aging that happens on patients, and you can help to attenuate that through exercise. You also want to use exercise to try to facilitate the completion of treatment. What that means is back in relation to the dose delays and the dose reductions that we see with chemotherapy. So if someone is not tolerating chemotherapy well, oftentimes what physicians will do is they'll give them a lower dose of that chemotherapy, or they'll say, go home and rest, come back in 7 days, and we'll try again. You're just not healthy enough right now. So exercise can help keep that immune system strong so that they have fewer of those dose delays and dose reductions. Anytime you have a dose delay and a dose reduction, it's going to, it's going to make it harder for you to beat that cancer. So we want to try to avoid that as much as possible. And ideally, with exercise, we can facilitate the completion of treatment and potentially enhance the treatment efficacy. At a minimum, we can use exercise to attenuate, if not improve, some of the treatment-related declines that we see in skeletal mass and muscular strength and cardiovascular function. We see patients, we now have had more than 20,000 patients go through our program at Mapletree over the last 14 years. Time and time and time again, we have patients who finish chemotherapy and finish radiation stronger than what they were when they were first diagnosed. And if you go all the way back to, 20, 30 years ago, patients were told they should rest during chemotherapy and during radiation. And we're saying, no, actually, if they exercise, they can potentially finish chemo and finish radiation stronger than what they were. That's completely changing the narrative of cancer. And it's giving people so much hope for what their potential outcome may be. So let's look at the general classes of treatment and how we can adapt the exercise program accordingly, depending on where someone is. So first, we want to talk about surgery. Most patients who are diagnosed with cancer will undergo some kind of oncological surgery. And there's three different types, three different broad types of oncological surgery that the patient may have. The first is diagnostic. Think of like a biopsy, and that's mainly just to see, is cancer present? The next one would be definitive treatment. This would be if you have a small localized tumor that has not yet spread to the lymphatic system, and it's, in this one tissue of origin, and the surgeon can just cut it all out and remove as many, remove all the cancer cells. That's a definitive treatment surgery. And then the last one is for a palliative procedure. This is not going to cure that person of cancer. It's not going to get rid of all the cancer in their body, but potentially it can help improve their quality of life. So a good example of that is we recently had a patient who had stage 4 lymphoma. So cancer is everywhere in his body, and it was terminal, and he knew it was terminal. But as a result of the lymphoma, he did have a tumor that was growing in his chest. And it was growing to the point where it was making it difficult for him to breathe. So even at rest, even when he was laying in bed, he was experiencing shortness of breath. And that is just not a good quality of life, even in someone who's dying from their cancer. You don't want to be laying in bed feeling like you can't catch your breath. And so he underwent a palliative surgery to reduce the size of that tumor that was in his chest to make it easier for him to breathe. Now, he ended up still passing away from his cancer, but doing that surgery did improve his quality of life for the remainder time that he had. So that's an example of a palliative procedure. Now, it's very common after surgery for patients to feel fatigued, to feel deconditioned. Oftentimes, they might experience some nausea, they lose their appetite, they have sleep disturbances, they have pain in the impacted area. These are very common. Now, the severity is going to really depend on the location and the invasiveness of the surgical procedure that took place. And it's very common that they're going to have pain, in that area where the incision was made. And typically, this pain is going to be measured through a visual analog scale. So, on a scale of 1 to 10, and they'll have like the happy faces all the way down to the sad faces. And you can identify what your pain is according to that. Now, keep in mind that pain control oftentimes is going to be a limiting factor that's going to prevent patients from returning to baseline activities of daily living, from ever even ambulating at all, and sometimes even from being discharged from the hospital. And so you want to keep in mind that that is a reality. But what can exercise do? How can we help that patient with exercise while they're in surgical recovery? So, early rehabilitation programs, research shows, can improve pulmonary function, it can reduce fatigue, it can improve functional mobility, and it can decrease that patient's length of hospital stay. And so, keeping in step with the guidelines that the physician lays out whenever you get that physician clearance, exercise is possible when someone's in surgical recovery, and it can have some beneficial effects on that patient. You can also see an improvement on functional capacity, mood, immune system, psychosocial outcomes. Sometimes patients have so much anxiety and so much fear, and then they figure out, like, here's something positive that I can do to positively impact my treatment. That has a huge impact on that patient. And so giving them that empowerment to help them through their journey is so important. So, just some special considerations when you're working with someone who's in surgical recovery. You want to avoid excessive intra-abdominal pressure because that individual is going to be at risk for a hernia if they perform too strenuous of exercise too soon. You want to establish consistent infection prevention practices. So always keeping in mind, like, where's the incision site, and making sure that you're, keeping that area clean, and then any of the equipment that you're using nice and clean. And then you also want to assess fracture risk prior to starting an exercise program in any patients that have bone metastases, osteoporosis, or are on hormonal therapy. So now let's look at radiation therapy. First, I want to explain what radiation therapy is. Radiation therapy is the use of high energy particles or waves that can destroy cancer cells. So essentially what they do is they get into the DNA of the cancer cells. And if you kind of envision it like it's that helix that's kind of wrapped around each other, and it makes small breaks in the DNA of that cell. And that is going to prevent that cell from growing and dividing. So if you were here for the cancer biology lecture that I gave, I think that was my second webinar series, we talked about cancer cells, and what is happening with cancer cells is they're growing and they're dividing out of control. So if radiation therapy stops that cancer cell from growing and dividing by making those breaks in the DNA, then that's going to cause that cancer cell to die. So that is what we want to happen ultimately with cancer. The thing with radiation, and this is pretty minimal now, but there are some normal and healthy cells that can be impacted with radiation therapy. Most of these cells will recover and go back to working the way they should once radiation ends. Radiation can be used to shrink the tumor. It can be used to prevent cancer recurrence, to treat symptoms that are caused by advanced cancer or metastases, and they can be used to relieve pain or trouble swallowing or breathing, similar to that patient that I discussed, or any bowel blockages. So there's many different ways that radiation can be used. And the side effects of radiation, are pretty common, from patient to patient. Oftentimes they're going to have fatigue. I think fatigue is the most common, most severe side effect of radiation therapy. Also, sometimes patients will experience skin problems like skin burns from the radiation. Sometimes they may experience hair loss. Sometimes they're going to have eating problems due to mouth sores or nausea and vomiting. Sometimes you'll see low blood counts, digestive problems, and there is a slightly increased risk of another type of cancer, developing another type of cancer down the road because of radiation exposure. When you're exercising with someone who's currently in radiation, and we're looking at the FIT principle, so frequency, intensity, time, and type, you want to follow the exercise guidelines that we saw with the healthy population. So aerobic exercise training, try to hit that 150 minutes per week goal. Resistance training, try to hit 2 to 3 times per week. If you're looking at intensity levels, you want to go between 60 and 70% of heart rate reserve for aerobic exercise training as that patient is able to tolerate. If they've never exercised before and they're experiencing significant fatigue from their radiation, they may need to start at, 35 or 40%, and that's okay. Start where they are and then gradually get them up to the 60% goal. Maybe week 1, we're at 40%. Maybe week 2, we go up to 45%. Maybe week 3, we have a setback and we need to go back to 40. Be able to adjust and gradually work that patient up to that 60% if they're not able to do that right from the beginning. With resistance training, again, you want to use the patient, see what they're able to do. Ideally, if you could get to 60 to 80% of their 1RM, that would be great. That's a great strength building program. If they're not able to, do a lower percentage of their 1RM and have them do more repetitions of that particular activity. And ideally, you want to see at least 2 sets of between 6 and 8 large muscle groups for resistance training. So 1 exercise for the back, 1 exercise for the chest, 1 exercise for the quads, 1 exercise for the hamstrings, making sure you're getting all the major muscle groups. And I always like to do the functional activities whenever I'm doing resistance training. So, a squat is great because if someone can do a squat, then they're going to be able to get up and down out of a chair. If someone can do a lunge, then they're going to be able to go up and down stairs. So those are things that are really important. Being able to do an overhead press, if a patient can do that, well, then now they're going to be able to get a glass out of the cupboard. They're going to be able to wash their hair. And so think of the exercises that you're doing and what is the impact on the functional ability of that patient when they do that exercise. And keep that in mind when you're doing the resistance training. And it might help to explain that to the patient so that they can see this isn't just a squat. This is something that'll help me every day. I'm going to have to get up and down out of a chair. And if they see that, that's going to help them stick to the exercise program. And then finally, I want to talk about infusion therapy and how to do exercises during infusion therapy. So, when we're talking about infusion therapy, that's going to involve the administration of medication through a needle or through a catheter. And this is going to be the common delivery method for both chemotherapy and immunotherapy. So, just quickly, immunotherapy side effects are going to really be dependent upon the dose, the type, and how the medicine is administered. Generally, what you see with immunotherapy are flu-like symptoms initially. So like fever, chills, muscle aches, nausea. This tends to be pretty immediate when immunotherapy is administered, and it will decrease with subsequent treatments as the body gets used to the immunotherapy. Now, chemotherapy is pretty much the opposite because as the dose, as the relative dose or the what's that called? I'm losing my train of thought. But as that total dose gets higher, sometimes what you're going to see is more symptom severity. But what chemotherapy is this is the use of drugs that kill rapidly dividing cells in the body or slow down their rate of growth. And so generally with chemotherapy, it's going to be administered in cycles. So the patient goes to a cancer center for several hours on one day and they're getting chemotherapy. And then they return, depending on what their treatment schedule is, they return anywhere from, oopsie, sorry. They return anywhere from, I'm sorry, how do I go back? Sorry, someone came in and I got sidetracked. They can come in anywhere from 1 to 3 weeks later for their next infusion round. And then that's going to be repeated depending on, how long the length of their treatment is for 4 to 8 cycles. So that means for a total of maybe 24 weeks, they're in chemotherapy treatment. They may come in once every 3 weeks to get their treatment for a length of time for that extends for about 24 weeks. It's going to vary from one person to the next, but that's generally how chemotherapy is administered. Chemotherapy cells, it's important to keep in mind that chemotherapy cannot tell the difference between a cancer cell and a healthy cell. It's programmed to go into the body and identify a specific cell that's in a specific stage of cell division. If you're interested in learning more, go back to that cancer biology webinar that I did back in week 2. I believe that was February 20th. And that it goes through, basically what the cell cycle is and how chemotherapy can go in and target those specific cells in that specific cell cycle. And it can't tell the difference between a healthy cell and a cancer cell. And so what happens is you see healthy cells that rapidly divide they're getting killed by the chemotherapy. And that's why your hair falls out. That's why you have skin problems. That's why you experience fatigue. That's why chemotherapy is given in cycles, because the body needs time to rest in between cycles and recover before receiving the next dose. So some common side effects of chemotherapy, you see nausea and diarrhea, significant levels of fatigue, reduced immune function. That's why every time someone goes in for a chemotherapy cycle, the doctor is going to look at their white blood cell count to determine if they're healthy enough to get chemotherapy or not. And then, of course, hair loss and nail changes, because hair and nail are going to be one of those cells that rapidly divide. So they're definitely going to be impacted by chemotherapy. Sometimes these effects are going to resolve soon after the completion of chemotherapy. So your hair will grow back, your nails will resolve. Others persist for a long time. So some people are not aware of that. Some people experience fatigue for weeks, for months, for sometimes even years after the completion of chemotherapy. And they may or may not have realized that that is the reality. And that's just one of the negative realities of cancer treatment, is that sometimes you do have these long-term and late effects of cancer treatment that take a long time to resolve. So when you're prescribing exercise for someone who is in chemotherapy, number one, first and foremost, is you want to avoid inactivity. And so being able to do what you can. Some activity is better than no activity. Ideally, we want to aim for at least 150 minutes of moderate intensity exercise or 75 to 150 minutes of vigorous intensity exercise. I personally would not recommend vigorous intensity exercise during chemotherapy unless that patient was well trained before their cancer diagnosis, just because you do want to protect their immune function. And then the resistance training on 2 or more days per week. During infusion therapy, you do want to keep in mind that there are some barriers to completing the exercise session. You have these treatment symptoms and side effects that you have. The patient may have conflicting doctor's appointments. They may have, 3 or 4 doctor's appointments per week, plus family commitments, plus work commitments. And it might be difficult for them to then find time to exercise. So helping them to troubleshoot with that. Sometimes we do see a decrease in attendance of exercise sessions as the accumulation of symptoms progresses. Um, that is why, and we're going to touch on this briefly. That is why behavior support strategies are so important. You want to encourage exercise in later chemotherapy cycles. One of the things that we recommend when someone is experiencing the fatigue is the frequency of exercise. So maybe 30 minutes of exercise in one setting is going to be just too much for a patient who's experiencing fatigue. You can take that frequency. You can take that 30 minutes and break it up into several short-term bouts throughout the day. So 10 minutes in the morning, 10 minutes at lunch, 10 minutes at dinner. At the end of the day, you have 30 minutes, but you've been able to break it up. That really will help to decrease fatigue and kind of keep it decreased as the patient goes throughout that day. With intensity, we have already discussed you want that patient to avoid inactivity and keep in mind that a lower intensity may be a benefit for that patient. Sometimes when you have higher intensities, you're going to see a decrease in patient adherence to the program just because it could be too taxing for them. Resistance training, you want to follow the principle of start low and go slow. So start with a low intensity weight and progress slowly as the patient is able to tolerate. With progression, as the body adapts to exercise, patients can progress even when they're in chemotherapy. You can increase the exercise intensity as the patient is able to tolerate. And so one of the things that I want to kind of show you about here with regard to physical therapy or to chemotherapy. You want to progress the exercise and intensity every 1 to 2 weeks as tolerated, but again, meeting that patient where they are. And so we have what we call a bad day adjustment. A bad day adjustment takes into consideration patients who have experiencing fluctuation in their side effects within the cycle. And so one week they may be feeling great. The next week they may come to you and they might just be having a terrible day. In that situation, what we do is we reduce the exercise intensity by about 10%. And we see if the patient is able to tolerate that. And so if you're looking at a linear progression here, it's not going to be linear. It may go up for 2 weeks and then we're going to bring it back down for that bad day adjustment. Now, the next time they come in, if they're able to tolerate back to where they were, we'll bring the exercise intensity back up. But if they're still not feeling well, we'll still keep it reduced at that 10%. And doing this allows the patient to know that you see them, you hear them, you understand that their side effects are going to fluctuate during their treatment journey. And they're going to be more likely to come back and they're going to trust you and they're going to know that you have their back. So I think it's really important to incorporate things like this. The next thing that I want to talk about is the chemotherapy periodized treatment. Essentially, what this does, this is a periodization of training that is built around the typical cycle length and symptom profile for a patient who's in chemotherapy. So if you look at this, this is an example of a chemotherapy periodized exercise prescription for someone who is in chemotherapy in 3-week cycles. So you can see here week one. Week one, this is a treatment week. So the patient has chemotherapy. We know that the week that someone gets chemotherapy and then they come to exercise, say 3 days after their cancer treatment, they're probably going to be really fatigued. They're probably not going to feel great. They're going to have low energy. They may not have eaten very much that week. They may have had nausea, vomiting, diarrhea, all of those things. And so that's going to be a hard week for that person. So we keep the exercise intensity low here for that week. And then week two, as their symptoms improve, we can progress the exercise program. Week 3, their symptoms have improved even more. We can progress even further. And then week 4, they've received chemotherapy again. So we know that's going to be a bad week. So we bring it back down again. So it's a non-linear, non-standardized approach to this progression when patients are in chemotherapy, taking into consideration the further you get from that chemotherapy treatment, the better the symptoms are improving, the higher the intensity you can go, but then lowering intensity on treatment weeks to account for, hey, you're probably not going to be feeling good that week. But you can see over time, we're still increasing intensity. If you were to look from 1 all the way here to week 11, you still have had a 20% improvement in intensity. It's just not going to be a linear improvement based on the symptom severity of that patient. So that's chemotherapy periodized training. We do this with our patients who are in chemotherapy treatment. This helps with adherence to programs. It helps with the attendance to their exercise programs, and it helps build trust between that patient and their exercise trainer. And then I've already kind of touched on this, but patients who have gone through our program, of course, cancer is cancer. People still have, bad outcomes with cancer. But for the most part, this is the data that we see when someone is in phase 1. So chemotherapy, radiation treatment, we see an almost 60% improvement in quality of life, 15% improvement in cardiovascular endurance, 18% improvement in muscular endurance, 32% improvement in flexibility. Patients feel supported, patients feel positive. Overall, ideally, we want this to be the best thing that they chose to do while they're going through chemotherapy. We want them to look back on their exercise program and say, I couldn't have made it through without this. And you see numbers like this and you see, like, yeah, this really does make a positive impact in someone who's going through cancer. We also see a decrease in healthcare utilization. We're using this data to advocate for insurance reimbursement and also to get into new hospital partners. But more than that, this also impacts the patient as well. If we can keep the patient out of the hospital, or when they're in the hospital in their shorter amount of time than what they should be, if they can have fewer ER visits, all of those things are going to positively impact the patient. And when patients exercise, they do have lower healthcare utilization because they have better symptom management. And so you do see a reduction in healthcare utilization. Your role as the exercise oncology professional is to perform the patient assessments, to individualize the exercise program, to conduct the one-on-one training, to monitor the patient's progress, to educate them so that you can build their self-efficacy so they continue to exercise after their time with you comes to an end, and to document and report the patient improvements as they go along the way. If you would like to learn more about Maple Tree Education, please follow us. We have our YouTube channel here. All of these webinars are posted on the YouTube channel, so please feel free to subscribe to that. We have a Maple Tree Education platform on Instagram and on TikTok, where we break down the latest research, we give training tips, we give kind of an insight on like the behind the scenes on what it's like to be a trainer working in this space. So I think you'll find a lot of very valuable information here and a lot of insight to what it's like to work in this profession. So that is all for today. I'm going to pause recording.